First of all, I have to go through my disclosures indicating my involvement with research and potential conflicts of interest that you should be aware of. We have, over many years, had funding through the CIHR, the Canadian Institute of Health, the National Institutes of Health, the Alzheimer's Society of Canada, Physician Services Incorporated, and Lawson Health Research Institute. I have been involved with a consultant and done continuing medical education for family physicians, and we've been involved with clinical trials funding with the companies listed below on the left, and then a number of other companies over the years listed on the right. Part of this is a testament to the effort that many different groups have actually done over the years to actually try and find ways to actually slow Alzheimer's disease. And we are still seeking the potential for being able to slow this disease, and we'll speak a bit about that at the end. The learning objectives for this evening is really to look at what we refer to as the spectrum of cognitive decline and talk about some of the common underlying diseases for why people develop cognitive impairment or memory problems as they get older. Alzheimer's, which is the one which you'd be most commonly aware of, strokes, Lewy body disease, frontotemporal dementia. We'll speak about some of these. We'll also discuss when it might be important for you to consider seeing a family doctor, what you might expect when you go and see a family doctor, certainly what we would hope you might expect when you see the family physicians, the family health teams, and the other practitioners, nurse practitioners that you might see in primary care. Want to learn a bit about the risk factors for dementia and what you might be able to do to lower your risk and try and keep your brain healthy. We'll give some updates on research and then learn about the opportunity to participate in research, because we're not going to learn anything more about this disease unless people are engaged. So people with the condition, but also their caregivers, people without the condition but may have the risk of developing cognitive impairment as they get older. Alzheimer described this disease over 100 years ago, and this is the person, the index person that he described at the time. She was 52, and very quickly she progressed, developed, beginning with memory impairment, developed paranoia, immobility, and died after 4 years. And at autopsy examination of the brain, he described things called plaques and tangles, and I'll show you some representations of those later. This became known as Alzheimer's disease, and for many years we thought of it as a disease which began in younger ages, in 50s and 60s. We also recognized that people in their 80s had something that the lay people would refer to, the lay terminology was senility or senile dementia. By the 1960s, when we looked at the brain tissues of people who had developed at a young age and an old age, the changes were exactly the same. So these terms that are listed there are really synonymous. They all mean the same thing. The more recent term that we have evolved towards is dementia, probable Alzheimer's disease. Now, it is important for us to think about, because it does involve a large number of people, and if we project forward another 18 years, this may be well over 1 million people in Canada, which is a huge burden. It's important to recognize that 50% of these people will continue to live in the community and are very ably supported by informal caregivers, which are family members who are supporting them there, with additional supports which come through the various organizations that are at the back of the room. And I strongly encourage you at the end of the presentation to go and learn about what additional formal resources are available. It's important also to recognize that It's more common in old age, so we'll talk a bit more about that, but it's not because of getting older. There is an estimate of the economic burden, and this came from the Alzheimer's Society of Canada in their seminal document, the Rising Tide, published in 2010, and you can see there that these costs are really quite astronomical, not only in the direct costs, but in the opportunity costs lost for informal caregivers and the indirect costs. Some of you may have seen this diagram at the Aging Brain and Memory Clinic. We use this commonly to describe the spectrum of cognitive decline. And so on the far left, we regard people who are supernormal as people. These are people in their 80s who score the same as 20-year-olds on memory tests. These are quite remarkable, but few individuals. There are people, more commonly, people in their 50s, 60s, 70s, 80s, occasionally forget things, occasionally misplace things. When we do a memory test with them, they're in the normal range. The test we use is the MoCA, and I'll show you that later on, the Montreal Cognitive Assessment. They score 26 or better. They have no concerns about memory problems. People with subjective cognitive decline are people who have noticed a change. They say, my memory has changed over the last 3 years, and they're concerned about it. Now, I mentioned memory. It's most commonly memory, but they could also be presenting because of language problems. They may be presenting because of behavioral problems or changes in personality as well, and this relates to some of the different types of dementia. But the most common presentation, the thing they notice first, other people may notice, is memory loss. So people with subjective cognitive decline may be aware they're having memory difficulties. Because it's so early, only they may be aware of it. It may be occurring at work, but no one else is aware of it. Their family members may not be that aware of it. And they also score in the normal range, 26 or better on the MoCA. People with mild cognitive impairment, on the other hand, have definite progression of memory impairment. You can actually measure it over time. If you do repeated Montreal cognitive assessments, you can see that there is a decline over time. And they're impaired with their memory, but their instrumental activities of daily living are intact. So the things that they do on a day-to-day basis, grocery shopping, banking, driving, yard work, housework, cooking, all of these things are essentially normal. They may be a little bit slower, but they do them in a normal fashion. Dementia, on the other hand, is where they not only have cognitive impairment, but they have impairment in one or more of those instrumental activities of daily living. Now, across the bottom, you can see there the scale 65 plus and 85 plus. In Canada today, 8% of people have dementia, those 65 and over. 17% have mild cognitive impairment. So that means that 25% of people 65 and over have some form of cognitive impairment. That's the group. It doesn't mean it happens when you get to 65. It just means the group as a whole. That's the proportion. And 75% are normal. But once you get to 85 and over, 1/3 have dementia, 1/3 have mild cognitive impairment, and 1/3 are in the normal group. And then this can obviously progress. If we break this down by prodromal dementia, that is the interval between mild cognitive impairment and dementia. And then this can then go on to be mild dementia, moderate, severe, and advanced. And people with these later stages of dementia often can't be managed at home and may be now cared for in long-term care. Along the bottom, you can see another measure of memory called the Standardized Mini-Mental State Exam. This is an instrument that's been around and described first by Falstein in 1975. And this is broken down. It's also scored out of 30. But you can see, for the purposes of clinical trials, we can see the scores there. So someone with a score of 20 to 26 typically falls within what we would call mild dementia, moderate dementia 12 to 19, and then severe dementia less than 12, and often once you get to advanced dementia, it's not even possible to do any sort of memory testing. This is looking at the progression of dementia in years across the bottom, across the x-axis, and across the vertical axis is the mini mental state score. So you can see that there is a decline over a number of years. Now, this is not the typical pattern for every single person. This is an average pattern. If we took 1,000 people, this is what it might look like. But you can see it's not a straight line decline. It is a sigmoid curve, reverse sigmoid curve. You can see the symptoms begin very early on. Out to the left there is what MCI, or standing for mild cognitive impairment, and you can see it progresses. And where families often become concerned is where they start to experience this more rapid decline, with the steep change on that slide where you go to the point of diagnosis. This is where they're seeing the changes. So they're saying things have been changing very slowly after the last 3 to 5 years, but now over the last 6 months, things have got much worse. There's also loss of functional independence, so those activities of daily living are being impaired, and that's how that diagnosis is made. There may be behavioral problems developing, nursing home placement, and death. Now, we should talk a bit about the risk factors for cognitive impairment. These are things on the left side are the things that we can't really change, with the caveat that if you plan on getting old, be careful what you wish for. It's you need to factor in and put in some of the things on the right to try and make things less likely that you will develop cognitive impairment. So all of those things there, we're going to talk a bit more. You can read them there. But these are some of the things that particularly a family physician is going to want to assess and try and treat and reduce the likelihood of these things making cognitive impairment more likely. Now, we should just look at cumulative risk, because a person, we talked about age alone. So at age 60, the risk of developing dementia of any type would be about 1%. 65, 2%, 74%. So you can see as you go up every 5 years, there's a doubling of the risk. However, if you have an additional risk factor, like one of the ones that we had shown on the previous slide, so high blood pressure, cholesterol, diabetes, any of those, the risk again doubles again. So if you have age plus 2 risk factors, you can see now that at age 80, the risk of actually having dementia is 64% as opposed to 16% if it's just age alone. So this is really why we want to emphasize looking at that list of reversible risk factors and looking and seeing what you can actually do about it to reduce your risk over time. I'm just going to touch on briefly the criteria for making the diagnosis of mild cognitive impairment. I've talked about it, but there is a formal criteria that we actually use for making the diagnosis. So we want to get a history from you, the family members, and these are things that you can make observations about if you are going to see a family physician. Seeing that there is a decline in the person's performance, that it's been evident over time, and it may be relating to memory. It can be planning or executive function. And a good example of executive function might be someone who's very good at cooking who now can't assemble a meal in the way that they used to be, particularly some of those occasions where they're having the family over, there's more stress. It's a big undertaking, and they're trying to bring many different courses together, put them all on the table in a sequence that's planned. The food may start to, people may say, well, this doesn't taste the same way as it used to be cooked. And so these may be some of the clues that family members may notice that things are actually changing. It could also be another member of the family who was always very good and proactive about planning a trip, a vacation they were going to go on, and now they are no longer doing that sort of thing. They used to do that, and now they're just waiting for everyone else to do it, or someone else to do it. This is with mild cognitive impairment, we ask family members about the preservation of activity. So if there is observation of memory impairment and all of the activities of daily living are preserved. This fits with mild cognitive impairment. It's important there to confirm it with a family member. So we always want to try and talk with a family member and do that alone, particularly if it's a very sensitive area that they're wanting to talk about. Sensitive areas particularly would be things like driving. You know, if you're uncomfortable with changes that you're seeing in someone's driving, you don't want to say that in front of them to the doctor, because you're going to hear about it all the way home and later. So the other thing about mild cognitive impairment to actually know that it is progressive is actually measuring that change over time using those repeated MOCAs. And so as specialists, we work very closely with family physicians. They may do 1 or 2 Montreal cognitive assessments in the clinic. They will send those with the referral. We may see the person 6 months or a year later. We will do one. We will send it back. We will do it back and forth. So that's information that they share back and forth. They do it in a standardized way. So it is a reasonable proxy and way of measuring changes over time. Dementia due to Alzheimer's disease, in contrast, it still is an insidious progression over months or years. This is not a very brief change over hours. That's more likely to be something like delirium. So some of you may have seen delirium, which is that acute confusional state you may see in an older person, say after surgery or in response to an infection, pneumonia. They may become acutely confused. Dementia is something that occurs over months or years. And then you may find that memory is certainly impaired, and usually we look to see if another cognitive domain may be affected. So commonly a person with early dementia may also have word-finding difficulties. They may have impairment in what we call visuospatial impairment or face recognition. They may not recognize people that they know well. They may have difficulty with spatial or geographic orientation. They may also show impaired judgment and problem solving, which we refer to as executive dysfunction. And then usually, if there's no strokes or anything like that going on, they appear normal from a neurologic perspective. So if we do an examination, their reflexes are normal, they walk normally. There's nothing there that would suggest a focal neurological sign to suggest a stroke or a brain tumor or something else that might be causing this. And then what we encourage families to do is to take these changes seriously. So there are changes in memory, language, or mood, which are sort of common presentations in older people. An older person in their 60s who for the first time has never had depression and now appears to become withdrawn and depressed for no apparent reason, this may be a forerunner to early mild cognitive impairment, early dementia. So it's something to pay attention to. Mention it to the family physician, and hopefully the family physician who's attuned to that person will be able to take it seriously and be able to administer a MOCA, or one of their staff may. Now, I've talked about the MOCA. This is what it looks like. This is one of the 3 versions. It is in many different languages. And you can see in the top screen there animals. So usually we start with the animals and we go in an anti-clockwise direction. So we ask a person to name the animals, and then they draw a clock face in the square above that. And they're asked to make the clock and put the numbers in the clock and to put the hands at 10 past 11. Now, some of you who have actually gone and done your driving test at age 80 might remember that this is the test that they do for the driving test. And at the Ministry of Transportation at 80, they have to draw that clock test. It's one of the cognitive tests that's done as a brief cognitive test to see whether or not someone has cognitive impairment, and even to raise the possibility of whether or not they should be driving. There's a cube copy there, and then there's what we call the modified Trails B with the this is an abbreviated version, and what a person has to do is to draw a line from the first number to the first letter to the second number to the second letter in an alternating fashion until they end up at E. And this is a test of executive function because you have to remember to switch. It's a switching task, and we liken it to driving, although it's not a driving test. Now, there's the longer versions of this where there's 13 numbers and letters, and this is a more exacting task, and it's a time task, and we look to see whether or not there are errors done to know whether or not someone might be able to drive. And then there are the words below. You can see the words there: face, velvet, church, daisy, red. So you say that to the person once, and they say it back to you, and then we give a second trial: face, velvet, church, daisy, red. Those are the 5 words they're asked to remember. So we'll go on, and then what we do, there are tests of attention which are listed there. Those are numbers forwards and numbers backwards. There's a tapping test. We have to tap the desk every time you hear the letter A. There's some serial 7s. So some people who have maybe not extensive education or may have not been good at math may struggle a little bit with this, but it is reduced the score, scored out of 3. You take 7 away from 100 to 93 to 86, 79, 72, 65. There's a couple of sentences there that have to be repeated exactly as they're written. So I only know that John is the one to help today. You have to say that exactly to get the point. And then the cat always hid under the couch when dogs were in the room. You can't add additional words or leave out words. Then they're asked to say the number of words beginning with a certain letter. In this instance, it's F, so as many words as they can. This is looking at fluency, and it's verbal fluency, what's particularly called phonemic fluency. And then there's a couple of tests for abstraction, similarities between a banana and an orange. The answer to that is a fruit. I could ask you this next, but similarities between a train and a bicycle. Transportation is what we're looking for. So it's the abstract form, and then the similarities between a watch and a ruler. Pardon? Measurement, yes, you've all got that, so that's good. So you're doing really well. So this is where we go to, well, we're really getting into audience participation now. So, okay, so let's see, try this next bit. See, collectively, if you can come up with, what were the 5 words that I asked you to remember? Did someone say red? Okay, good. Excellent. Okay, so collectively you did really well. Okay. That's good. Okay. And then there's the points orientation to date, and that's the day of the week, the month, the year, the day, place, and city. And that's scored out of 30. And so 26 or better, with no complaints of memory, would be in the normal range. If there were complaints, that would be subjective cognitive decline. If you scored less than 26 on that, this would be into mild impairment. And then if the instrumental activities of daily living were impaired, significantly impaired, then that would be dementia. There are blood tests we do. We want to rule out reversible causes due to certain blood tests, and they're listed there. We want to look at the thyroid function, the diabetes, electrolytes, kidney function, calcium, and the vitamin B12 level. We'll often do some sort of neuroimaging, which would be either a CT scan. If someone's got a pacemaker or they're claustrophobic, then they may not be able to do a magnetic resonant imaging or MRI scan. The MRI gives us a better picture of the brain, and we want to look at it and see if there's any shrinkage of the brain, any more than we might expect in a person of that age. We want to see if there's any shrinkage of the hippocampus, which is the part of the brain involved with memory. And then there are different indications there for why we might do the imaging, but for most people, these days, we would actually do some form of imaging, either the CT or MRI. Now, we want to talk a little bit about the changes that are occurring at the cellular level in the brain. So this is artist's rendition of what Alzheimer saw, the amyloid plaques and the neurofibrillary tangles. So This is normal nerve cells on the left talking to each other, communicating. Each one of those nerve cells, we have billions of those nerve cells in our brain, and if you think about it, the synapses, those little extensions that go out, each one of the nerve cells can have 2,000 connections. Just think about that, the amount of connections that can be there. So it's quite phenomenal. With Alzheimer's disease, the change were these plaques that he saw, and we know that these are made of an amyloid protein, and I'll talk a bit later about the amyloid protein and where some of the research is going to try and remove some of that amyloid from the brain. And inside the nerve cells are these neurofibrillary tangles. So the amyloid accumulates over 10 or 15 years, long before a person ever has any awareness that they have any memory problems. The tangles start to disrupt. They follow on after the plaques, this is what we believe, and the tangles disrupt the functioning of that nerve cell and eventually kill that nerve cell, so that nerve cell doesn't work anymore. Both of these are due to naturally occurring proteins, amyloid protein and tau protein, T-A-U, tau protein, in the brain, and they become misfolded. They become abnormally folded. And we don't entirely know why they become misfolded. The second most common form of dementia is due to vascular dementia, where there's changes due to small strokes. An older term that was used was called multi-infarct dementia. Infarct is a term used for strokes. So people who have multi-infarct dementia will have progressive decline in their cognition, but often it will be in a stepwise way. It won't be a smooth transition. It will occur after they've had a stroke, and after the stroke they may improve for a period of time, and then if they have a further stroke, it may be a small or larger stroke, they'll have a further decline, maybe in their language, in their cognitive ability, maybe in behavior. And these things are evident on head CT scan or MRI, and I'll show you a picture of what that looks like. There may be often multiple strokes and changes in what we call the white matter in the brain. And the white matter is part of the brain that connects different regions of the brain. The deficits in cognition that has been seen in these people is, again, not occurring during delirium. Delirium was that acute confusional state that occurs often after an acute illness in an older person or after surgery, or in response to anesthesia or narcotics, things like that can cause delirium as well. So this is an MRI scan. So you have to imagine at the top of the picture is the front and it's going to the back. So it's a scan that's going through the brain this way from front to back. You can see the skull around the outside. You can see the linings of the brain around that. And then inside that you can see the wriggly parts of the brain, the grey area, which you're familiar with when you look at brain. This here, you can see these sulci here and these gyri, these bits here. And you can also see some of these strokes here. This is a small stroke. Here's another small stroke back here, and another one back here. As well, you can see some of the white matter changes, which is here. So in this particular type of MRI sequence, we can see the white matter changes. The wiring in the brain tends to go around the ventricles. The ventricles are these central bodies within the brain where cerebrospinal fluid, or CSF, is made in the central part of the brain. So CSF is here, and it flows out of the brain all the way down to the tailbone and then back up again outside the brain and over the top, and is reabsorbed here. But this shows grey matter out here, white matter here, and these small strokes. So a person with high blood pressure for many years, diabetes, smoking, elevated cholesterol, they may have quite a lot of white matter change. Now, it doesn't always correlate that. Sometimes it's very surprising. Some people may have a lot of those risk factors and have very little in the way of white matter change or even strokes. And that's part of the differences between different individuals. With a family doctor, what we would want them to do is to manage those vascular risk factors for looking at the brain and heart health, to treat those conditions there. Atrial fibrillation is the one where you have the irregular heartbeat. You want to put a person on a blood thinner for that to reduce the likelihood of clots going to the brain. We look at medications which might affect thinking, and that could be alcohol. If a person's drinking alcohol regularly to excess, can be a problem, particularly some of the drugs which cross the blood-brain barrier. They may be taking those drugs for other reasons, for pain conditions, chronic pain, fibromyalgia, for arthritis. They may be on narcotics, but they may also be having an effect on a person's thinking. And then they may have depressive symptoms which need to be treated. The other things that a family physician may want to address, things relating to capacity to make a will, to do power of attorney, to drive. And they may also at some point talk about a person's wishes regarding natural death versus wishes for resuscitation. But then at the same time paying attention to the lifestyle things that we can change. And we're going to go into a little bit more of that later on. Frontotemporal dementia is a third type of dementia, and there are 7 different variants. I'm not going to go through all of those. The ones that you may be aware of, you may have heard of Pick's disease, which is a so-called behavioral variant of frontotemporal dementia, and often this may present with disinhibited behavior, changes in personality or apathy. And there's some very exciting research being done in London. Dr. Elizabeth Finger and her team, Christy Coleman is at the back there, and she's waving her hand, and she would be interested if you have anyone who has, or you have family members who have frontotemporal dementia, or if they are the other variants listed there, the ones relating to language impairment, or even there's another one called progressive supranuclear palsy is one of the variants. There'll be an exciting study coming out there. But these there's a lot of interest in this particular type of dementia, looking at treatments to try and control the symptoms and hopefully eventually find treatments which may alter the course of the disease. And again, a lot of these frontotemporal dementias are due to misfolded proteins. The language disorders of frontotemporal dementia is the so-called primary progressive aphasias. There's 2 principal ones. There's the progressive non-fluent aphasia variant, and these people present with language difficulties. Their speech becomes non-fluent, and they have effortful, hesitant speech. And then the semantic variant is people that can speak quite normally in a fluent manner, but they miss words, and they'll say, you know, that thing. They will keep referring to something as a thing. It's often the nouns that they can't find. Another type of dementia which you may have heard of is Lewy body disease, and this has some cardinal symptoms, early visual hallucinations, fluctuations in levels of consciousness, and Parkinsonism, and it's that visual hallucinations, seeing people that are not there. And people with Alzheimer's disease can sometimes develop Lewy body disease as a second type of dementia on top of the Alzheimer's disease. So this is particularly difficult for family members because not only are they dealing with progression of the Alzheimer's disease with memory impairment, then a person may start to have visual hallucinations, may develop these fluctuations in their levels of consciousness. So sometimes they're very awake, and other times they are quite somnolent, almost asleep, and so you can see that fluctuations. And they may be quite sensitive to certain medications, particularly the antipsychotic group of medications. So I mentioned Alzheimer's and Lewy body may overlap, but you can also get overlaps between vascular dementia and Alzheimer's disease as a common mixed form of dementia. And Lewy body can even be part of that mix. So this makes the diagnosis really quite complicated, and again is very dependent on the history that you as family members are able to provide. So your astute observations are really important to be able to share with the primary care providers you're seeing and with the specialists that you're seeing. For the vascular dementia, the thing that we want to prevent are strokes, so treating blood pressure. There's a guideline there, 130/80 would be a good blood pressure. We encourage people to measure their blood pressure at home if they can. Diabetes, having good monitoring and control of that, monitoring cholesterol, looking at diet, exercise, and medications, stopping smoking, and treating atrial fibrillation. And in some people, aspirin, a coated aspirin once a day may be indicated. Now, there are non-drug approaches to try and reduce the risk of cognitive decline, and I'm going to speak a bit about some of the evidence for the aerobic and resistive weight exercises, as well as the adherence to Mediterranean-style diet. So there is quite a detailed study with brain imaging's outcomes looking at physical activity, showing that there may be an increase in grey matter in people who have normal cognition, so people who have normal memory may well improve the integrity of elements of their brain when you measure it on an MRI. In people who actually have dementia, there are a number of randomized controlled trials showing that a combination of aerobic exercises, either low or high frequency, are beneficial to people. So exercising is an important thing for people, even if they have dementia, to continue to do. And some of you may have seen this whiteboard that was put together by Dr. Mike Evans when he was still in Toronto, and called, if you Google 23.5 hours, it's a very compelling video on the benefits of exercise. So you just put in 23.5 hours and it will pop up. There are longitudinal studies looking at physical activity and the prevention of Alzheimer's disease. And so a number of studies of people who at baseline had no memory problems. These are large studies, and they actually had a reduced risk of dementia. And the way we measured this is by looking at the risk ratio, and in this case, the combined risk ratio was 0.61, which is less than 1. And this is a good thing for it to be showing that there is benefit by doing this. This represents the Mediterranean-style diet, and there is a wealth of information on the Mediterranean-style diet. And you can see at the bottom that there is non-refined grains, fruit and vegetables, legumes, seeds, some dairy products, olive oil and nuts, and fish and seafood, some poultry. At the very top, in very small quantities, is treats now and again, sweets and red meat. So this is the sort of the frequency with which we should be engaging in these things. The Mediterranean-style diet, there have been a number of studies there, so longitudinal studies looking at people who have good adherence to a Mediterranean diet, comparing people who have a lower adherence to Mediterranean-style diet. And those with a higher adherence, they slowed the rate of cognitive decline and reduced the likelihood of progression to dementia. And there was one study which actually looked here at the combination of Mediterranean diet and exercise over more than 12 years. And you can see that the people who had high adherence to physical activity and a high Mediterranean diet score compared to the people who had the low physical activity and low diet score, that the likelihood of progression over that time to dementia was lower in this group. Now, obviously it doesn't prevent it, but it's less than here. So if you asked yourself, would you rather be here or here, most people would say they'd want to be there. So there is another important study called the Finger study, and this was done in Finland. It was the Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability. And this was in people aged 60 to 77, and they had different intervention groups: nutrition, physical exercise, cognition training, and vascular monitoring. And they had another group who received health advice in the control group. And the outcomes were improved cognition and reduced risk of cognitive decline for the intervention. So that was a very compelling study. And this is leading now to a worldwide finger initiative. So in the US, their study they're calling the Pointer Study. In Canada, our study is going to be called the Can Thumbs Up Study. And it's going to be a large study involving over 2,000 people, randomized to different interventions. So that's actually going to be on the horizon and something that you'll hear more about. There are these other emerging evidence, which I'm not going to go into, that we do need to pay attention to new and interesting ways to stimulate the brain, to socialization and engagement. Television doesn't count as mental stimulation. CNN doesn't count as stimulation. Alcohol and drugs. If people already have cognitive impairment, something that might affect their cognition, it doesn't make any sense for them to continue to drinking. And so I encourage people to cut down the alcohol and actually wean it out altogether and go to non-alcohol beer or non-alcohol wine. And hearing as a new one is interesting. This is one that's come out of some literature from Britain, where they are finding that people with hearing impairment are at risk of developing dementia. Now, we don't fully understand whether it is the hearing impairment that leads to that, and whether by compensating with hearing or by using other things like mental stimulation, whether one can actually compensate for that in some sort of way. But it is something to pay attention to. And there are potential mechanisms here. I'm just going to show this really just to give you an idea of the complexity of what's going on. So there are a number of things that these preventive strategies are working on. So in the top portion, a lot of these strategies are trying to work on improving cognitive reserve, other strategies trying to improve or reduce brain inflammation, and other ones trying to reduce brain damage. You can see that they all overlap, but core to all of them are exercise and adherence to a Mediterranean-style diet. So this is really just to talk a bit about some of the treatments in the last few minutes. So this is that same curve that we looked at before. You can see going from the left here, these are people who are normal, progressing down into mild cognitive impairment over several years, and then that steep decline that we talked about earlier. We have, this is the natural course of the disease. I must acknowledge this is the very good efforts of my colleague Sarah Best, who has put this together. I like it, Sarah. Thank you for doing this. And this is the line here where you may get some improvement for some of the modest effects from the 3 cholinesterase inhibitor drugs that improve the symptoms in a very modest way if you get a response. And then a person may improve for 6 months to a year and then gradually decline. This is so-called symptomatic treatments. There are here disease-modifying treatments as part of the clinical trials, and we're going to talk a little bit about this. If we don't have treatments there, but this is where a lot of our hope is. This is where we're trying to find diseases, treatments that would modify the underlying disease of Alzheimer's disease and slow that progression of decline. So although this slowly declines, if a person over several years was here as opposed to here, this person may not be driving, but they would be living independently in the community. A person here or here may be in long-term care or worse. So just the treatments that you may be aware of. I'm getting the sign. Okay. These are the treatments here, those 3 cholinesterase inhibitors with the years in which they were approved in Canada. We were involved with a lot of those clinical trials. Some of those companies that we listed at the beginning were the companies that actually brought these compounds to market. There is memantine is another drug which has been approved for moderate to severe dementia. It's not covered by the Ontario drug benefit. I don't want to overstate this. These effects of these medications are modest at best, but at least we've got something to compare with. So coming back to those plaques and tangles, just to remind you of what they look like, this is the way in which the course of the amyloid plaque is depicted, and the thinking of some of the current science around understanding Alzheimer's disease. So these people out here are normal. The amyloid gradually gets deposited in the brain in this way here, and then sometime later the tau tangles start to accumulate in the brain, and you get changes, alterations in the brain structure with shrinkage of the hippocampus, and then you start to get problems with memory. So you can see a lot of stuff is occurring before you actually start to get the memory impairment, and then what we call loss of clinical function here, going from mild cognitive impairment into dementia. So we can image this brain. We can now see amyloid, and we can do this using a PET scan. These are part of research studies, and just to show you the contrast between a normal PET scan and a person who has a lot of amyloid in their brain. This person likely has Alzheimer's disease. This is what we would call a positive PET scan. And then we have used these scans as part of clinical trials now. So a person will often have to have a PET scan before they go into a clinical trial, because if you're going to try and remove amyloid from the brain, you want to know they have amyloid in the brain to be removed. You don't want to be subjected to a compound removing amyloid if you don't have it there. So you want to know it's there. And this is what it looks like. So this is the people who are on the placebo, and you can see over the course of the trial of I think this was a 1 year, yes, 1 year there at top. So this is a placebo person, and you can see that there's more amyloid there over the year. This is the person on 3 milligrams. This is a person on 6 milligrams per kilogram. This is a person on 10 milligrams. And the interesting thing about this study, this is the first trial at a phase 1 level where we actually could see a treatment benefit, not only on the imaging, removing amyloid from the brain, but we could actually see some improvement on their cognitive scores, particularly at the higher dose. So this was very encouraging. It was the first time we ever saw it at phase 1, and that was about 3 years ago. We saw the results of that trial. And this is one of the compounds that there is still a lot of interest in. We also now using PET scanning, and this again is a research scan, we can actually image the tau protein. So this is the A-beta or amyloid in a PET scan, and these are 3 different individuals. A person here who's cognitively intact here, cognitively intact here, and this is a final person who has dementia. These are 4 different people, and you can see that there is tau occurring here, and it's in a different distribution from the amyloid, and you can see it concentrating on that temporal horn and in the entorhinal cortex of the brain. These are regions of the brain. Now this image of the brain is done the other way. It's done down through the brain this way. Instead, I showed you an image that went back this way. This one goes down through the ears like that. So 6 reasons why to consider participating in a randomized controlled trial. People who are on the placebo respond to a placebo. You've heard the saying, give them a placebo. You know, people do respond to placebos, but this is certainly true. There's a truism in that. Close medical monitoring during the study, so if there are medical problems arise unrelated to the treatment trial, those go to the family physician or to the specialist and they get addressed. You get stimulation and an interaction with a new group of people, referral to the community resources at the back there, people that you can help you as the disease may progress, continued access to the drug. So after the clinical trial, if the clinical trial is for 2 years and you've got 1,000 people, 500 on the treatment, 500 on placebo, at the end of 2 years, everyone then gets the treatment. So you have to think of the people in the placebo as getting a delayed treatment. They do get the treatment eventually, And this is particularly in trials where in the final phases of the evaluation of the drug in a phase 3 trial, which is one of the latest phases of the end trial, is where they offered the treatment as part of that phase 3 trial before it goes for approval. And then altruism is often the reason why people say, I may not benefit from this, but one of my younger family members may benefit from my contribution to the research. So this is often the thing that motivates it. There are trials. This is an observational study. Just to mention that there are things. This is a Canadian initiative we're very proud of. In London, Ontario, we're taking the lead on this. The group at the back there, all of the coordinators there, Sally, Sarah, Nada, and Isabella are involved with this trial and helping with enrolling people in this study. And you can see that we want people not only with all of the conditions we've already talked about, listed in the top there, 1,660 people, but 650 normal controls. So some of you, one or two of you, look a little bit over 60. And if you want to contribute, you can participate in the study if you would like, and you can talk to some of the coordinators at the back about that. This has been done across 30 sites across Canada. Our site here in London are taking the lead on this and training all of these, so we're taking a really big role in this. These are some of the biomarkers that we're looking at in the study. So this is a biomarker study, trying to find blood or cerebrospinal fluid or brain changes on an MRI scan that might predict, confirm the diagnosis, but also predict progression in the future. So if there are certain changes, would that predict where this is going in the future? Because often that's what families ask us, what's this going to look like in 5 years? A couple of new intervention trials. These are intravenous antibody studies, so they're given intravenous compounds. So this is a person with late MCI or early dementia due to Alzheimer's disease. There are memory test screening, and then they have an amyloid scan. So people can get an amyloid scan, a research scan, to know whether or not they have amyloid in their brain or not. If you find you don't have amyloid sufficient for it to be considered positive, that's a good thing. And it lets you step back. If it is positive, then you may want to consider participating in either of these studies. So one is a subcutaneous injection given every 4 weeks, and the other one is an intravenous antibody every 2 weeks. Is one any better than the other? I don't know. That's what the research is going to tell us. That's where we allow the science to advise what is going to be a successful trial or not, because we have had a lot of trials where they have not been successful. In this particular intervention study, which is going to be starting later this year, people with late, mild cognitive impairment, dementia due to Alzheimer's disease, the mini-mental score for these trials often are that range 22 to 30 over 30. And there'll be screening tests. Now, in this test, people don't have a PET scan. They actually have a cerebrospinal fluid determined by lumbar puncture, so that's done under local anesthetic. And they remove a little bit of fluid from the lower back, and then it's examined to see what the ratio of the amyloid versus tau protein is in the cerebrospinal fluid. And that's a trial, and the medication in this instance is an oral medication. So, Karen, I'm about to finish. Family, really, you are the people that are most important. So I hope I've impressed upon you the importance that you bring to the diagnosis. You're the ones that make the astute observations, share those with the family physician and the specialist. The observations have changed, memory moved. Last week we had a person who came, a family member, and many of you do this, but beautifully typed history of events, sequential over the last 3 years, and it all made sense. It was all there on the paper. It was there, things that they had to do. So I think this is where you can really help make those observations, take them seriously. Repeated memory tests over time using things like the MOCA is going to be important, and that's often a combination of results from both the family physician and the specialists. Looking at non-drug approaches, trying to slow the progression, and then having people participate in research is going to be important if we're going to have new understanding and advance our understanding. I'm just going to acknowledge the our group. We work, it's in a very collaborative way. My colleague, Dr. Jenny Wells, Dr. Elizabeth Finger, I mentioned earlier, Dr. Stephen Pasternak, one of the other cognitive neurologists at Parkwood Institute, Sarah Best, our research manager, Christy Coleman, I mentioned, all of our coordinators, Nada and Sally and Isabella at the back there, and then the nurse clinicians we work with in the clinic, Dr. Jennifer Fogarty, some of you may have spoken with, a neuropsychologist. We have an informatics group with Kirk Harrison and Jesse Cooper, a volunteer who works with us as a research assistant, and our collaborating groups, researchers in the London at the University and Roberts Research Institute.
Susan and I would like to take this opportunity to thank you so much for your time, your expertise, your knowledge. It really means the world for all of us.
Thank you. Thank you.